Okay. Hi, everyone. Thank you for joining us for today's webinar, EMS Response to COVID-19. My name is Carmen Sanders. I'm a member of the Makah tribe, and I'm a public health project coordinator with the National Indian Health Board. I will be moderating today's webinar. Also joined us is Courtney Wheeler with NIHB. She's a public health program manager, and she'll also be available to assist. A few things before we get started. Everybody should be muted, but just in case, we do ask that everybody mutes your mics. This webinar will be recorded, and we'll have time at the end of the session for questions and answers. So please, if you have any questions, go ahead and put those in the chat. And once the webinar is complete, we'll have an evaluation link will be available, but we'll also send it out through the email. And the slides and recording of the webinar will be available shortly after. And there was one more thing. Sorry, there's one more thing. And also shortly, after we get started, we'll have a poll available. If everybody could please participate in that. We were just interested in knowing who's joined us and where everybody's from. That will be available shortly. And today we're very grateful to have Dr. Chelsea White present. Dr. White is excuse me. My monitor is going, give me 1 second. Okay, got it. Dr. White is an emergency physician in the Department of Emergency Medicine at the University of New Mexico, where he serves as the EMS faculty and as director of UNM Center for Rural and Tribal EMS. So,
all right.
Dr. White.
Well, thank you very much for inviting me to present, and thank you to everybody who is watching. Looks like we've got a bunch of participants. This is exciting. And I appreciate the introduction. Again, my name is Chelsea White, and at the University of New Mexico, emergency physician and EMS physician, and the director of the UNM Center for Rural and Tribal EMS. So please, if you have any questions, feel free to put them on the chat. I will try to keep an eye on that as we go, or you can save it up till the end. I usually count on interaction with the audience to fill my allotted time frame. So I fear we won't come close to filling the allotted time if you don't ask any questions. So please feel free to at least drop in on the chat. It's a little harder to raise your hand in this forum, I suppose, but we will make do. Okay. So first, I'd like to say a few words about the UNM Center for Rural and Tribal EMS. This is a center within the Department of Emergency Medicine at the University of New Mexico, and it's in Albuquerque, New Mexico. So the mission of our center is to support and advance the field of out-of-hospital medicine in rural, frontier, and tribal settings through education, innovation, research, policy, and medical direction. And if it sounds like I just read that, I absolutely did. That is our official mission statement. Our center consists of two core EMS physicians. That's me and my wife, who is also an EMS physician, one EMS nurse practitioner paramedic, and now one EMS physician assistant. And we cover multiple rural, frontier, and tribal EMS agencies in New Mexico, Arizona, and in the National Park Service. We also work closely with the University of New Mexico EMS Academy to creatively address rural EMS education needs. So that's a little bit about us. This, of course, is New Mexico, the 47th state. There are 23 Native American tribes in New Mexico. And from an EMS perspective, there are 12 tribal EMS run or tribally run EMS agencies in the state. Reservations that do not have their own EMS agency are covered by the surrounding EMS agencies, surrounding municipal EMS agencies. The UNM Center for Rural and Tribal EMS provides medical direction for part or all of 8 of those 12 tribal EMS agencies and provides medical direction for municipal agencies covering an additional 4 reservations. So we do provide quite a bit of coverage in tribal areas in New Mexico. Today's presentation will focus primarily on the Pueblo of Acoma Fire EMS and Pueblo of Laguna Fire Rescue. Though there are also some pictures in here from the Tahajale Field Office of Navajo Nation EMS and from Pine Hill EMS, which is on the Rama Navajo Reservation. And these are used to illustrate the topics under discussion. Please note that all of the pictures of EMS personnel and of patients that are shown here are used with permission and are shown with the intent to help EMS agencies everywhere better care for their patients. Okay, so a little bit of background on the agencies that we'll be using to illustrate this topic. This is the crew of the Acoma Fire EMS. Acoma Fire EMS staffs 1 station 24/7 on their Pueblo with 3 to 4 EMS providers per shift, and at least one of whom is usually an EMT intermediate. Acoma Fire EMS does not currently have any paramedics, though hopefully this will change in the near future. And in 2020, Acoma Fire EMS responded to 693 calls for service. So that kind of gives you an idea of how big and how busy they are. Next door in the Pueblo of Laguna, Laguna Fire Rescue responds from 3 stations 24/7 with 8 to 9 firefighter EMTs per shift. And usually at least 2 of those, sometimes even 3 of those are paramedics. And in 2020, they ran 1,784 calls for EMS services. They also instituted a community paramedic program in late 2015, which we won't really talk about here, but would be a great topic for future discussion in a similar forum. So this is about EMS infection control and COVID-19. But to talk about that, I think we should first discuss what EMS infection control was like before COVID-19. This right here is a very typical pre-COVID EMS site. This is in Tahajale, New Mexico with Navajo Nation EMS. And of course you see gloves in this picture. Gloves have been standard provider protection in EMS for years. I remember a few dinosaurs of the day still taking off a glove to start an IV back when I started in EMS in the early 90s. But even then, that was the exception. Everybody had pretty much grasped the importance of gloves by then. But nothing had really changed from then until the immediate pre-COVID era. But if you look closely at this picture, again, typical of pre-COVID EMS practice, You see a patient that is being ventilated with a bag valve mask. This is an aerosol generating procedure. Someone here is about to start an IV. Sure, it looks like they're wearing gloves, but this is a fluid exposure and splashing risk as well. The lead EMT has gloves on, but no mask and no eye protection, despite the aerosol generating procedure and the fluid exposure splashing risk. And the, the EMT who is ventilating the patient has eye protection, but it's perched on top of his hat. He's not even wearing it. And then, of course, the almost humorous part of this is the paramedic doesn't even have gloves on. And so I guess he wasn't really planning on getting his hands dirty. And if you knew him, you would chuckle at that. But then you look at the equipment here, the monitor cables, the BP cuff. I'm sure that those have been wiped with a cleaning solution recently, but this was definitely not a standard procedure at that point, and probably wasn't even a written procedure. But again, everything in this picture at the time it was taken was to the typical pre-COVID EMS standard of care. Now, almost a year into the COVID pandemic, and looking through the lens of COVID-19, this picture is horrifying. But not only was this standard of care, this was actually a staged picture that was used in a training presentation of best practices. Now, it wasn't specifically for infection control, but in those such pictures, we tried very hard not to create anything distracting. So we made sure that we were following best practices for infection control. And of course, this was taken by me, the crew's medical director, and I didn't notice any of these things or take exception to any of these things that are highlighted. So again, nothing out of the ordinary in 2017, and good enough for training company-wide. But of course, COVID did come. And after watching it several months going through China and then Italy, we suddenly had to do something about it. And sadly, as many of you know, it arrived with a vengeance in many of the tribal communities here in the Southwest. Pictures and standards like those in the previous slide quickly became a thing of the past and became casualties of the new normal. So step 0 in the COVID response actually was planning, and that was to develop EMS treatment guidelines that addressed both the disease and protective equipment. You know, we've been dealing with influenza, RSV, and other respiratory illnesses for many years. And we never, and we even made it through SARS and H1N1 scares, but EMS had never really focused specifically on contagious respiratory illnesses. This shown here is the first portion or the top portion of the current University of New Mexico Rural EMS guideline for contagious respiratory illness. And that's a guideline that we created in February of 2020. Prior to this, i.e. prior to COVID, we didn't have a specific treatment guideline in our EMS treatment guideline set aimed at contagious respiratory illness. If you look at it, since many respiratory illnesses have similar symptoms, it is appropriately general and hopefully will be useful for all sorts of these illnesses and not just COVID. But importantly, for the first time really in an EMS treatment guideline, at least in our area, it spells out the PPE requirements for EMS providers when responding to patients with these symptoms. So as you can see here, because it truly is impossible to distinguish in the field between the flu or RSV or a cold or COVID. We wanted to make sure that all EMS providers would wear standardized protective equipment once they encountered a patient with any contagious respiratory illness symptoms. And those standard pieces of equipment are the N95 respirator mask, gloves, eye protection, and impervious gown. Additionally, since somebody always has to drive the ambulance, after loading the patient in the back of the ambulance, the driver should remove gloves, gown, and eye protection, should keep the N95 mask on, and should wash hands or use alcohol-based hand sanitizer before driving. And that's, of course, to try to keep the cab of the ambulance as contamination-free as possible. But once you get to the hospital, the driver needs to put on all of the stuff if he or she is going to help take the patient inside. The next part of this shows is another important part, basically saying that if at all possible, when arriving on scene, providers should begin the initial assessment at least 6 feet away from the patient and minimize patient contact as much as possible until there is a face mask on the patient. Now, when we first wrote this, face mask wearing was not very common. Now, obviously, this has become more common, but this was an early attempt and a continued attempt to keep providers and patients separate until adequate protective barriers could be in place. Now, at the outset of the pandemic, PPE resources were scarce. Luckily, this is less of an issue now, but at the outset, it was very important that we conserve PPE, use it when necessary, but not use it when not necessary. So because of this, it became important to identify which patients required PPE and which patients didn't. So the best way to do this is actually on the phone with the dispatcher. So EMS dispatchers were really faced with the important task of determining the likelihood of COVID infection over the phone, so that they could alert responding EMS crews to the need for full PPE or not. What you see here appears to be a very complex algorithm, and it is, but this is the Medical Priority Dispatch System card 36, which in Medical Priority Dispatch System, or MPDS, is used by many medically trained dispatch centers. The MPDS 36 card contains the algorithm that medically trained dispatchers use to query callers and then alert crews about COVID status of the patient or potentially others at that location. But a problem facing many of our rural and tribal EMS agencies here in New Mexico was that very few of our EMS dispatchers or EMS dispatch centers are medically trained. So non-medically trained dispatchers don't have access to complex algorithms like MPDS, and often just give address and a very basic chief complaint to EMS crews before they arrive. So to protect our crews that don't have access to medically trained dispatchers, we created a dispatch protocol that could be easily followed by non-medically trained dispatchers. And this simple algorithm helped establish the likelihood of respiratory infection so that the EMS crews could protect themselves before going into the residence. So right here, just having the dispatcher ask, has the patient had a fever? Has the patient been coughing? Is the patient short of breath or having trouble breathing? And does the patient have a known diagnosis of COVID-19, or has the patient been exposed to a known COVID-19 patient? And if any of those questions were answered with a yes, then the dispatcher would ask the patient to put on a surgical mask before EMS units arrive, and then over the radio would tell all responding units, patient may have a contagious respiratory illness, apply PPE before making contact. So a very simple algorithm with just a few questions to be asked in a standardized fashion, and a very simple warning that was easy to convey, easy to understand over the radio, so that EMS providers could know ahead of time that this patient was going to require the full PPE setup, or this patient had a lower likelihood of actually having COVID. So that was a very helpful pre-arrival information. Now, thankfully, our PPE resources have become less scarce, and many of our EMS services are now wearing PPE on every call. So the dispatch information, while still very helpful, is less critical from a PPE conservation standpoint. And even some of our agencies have even gone above the N95 recommendations. This is crew from Pine Hill EMS, which again is on the Rama Navajo Reservation, and covers their chapter, as well as surrounding off-reservation areas in southern Cibola County, New Mexico. And they're shown here responding to a call wearing N100 respirators and full face shields. So they definitely have some really good PPE down there. So far, we've discussed personal protective equipment and strategies to protect our providers from getting COVID from patients. But what about protecting providers and patients from residual infectious particles in the air and on surfaces in the back of our ambulances? I mean, would you feel comfortable with your child as a patient in the back of a potentially contaminated ambulance like this? Again, this was something that prior to COVID didn't really receive the industry attention that it should have, despite plenty of concerns in the EMS literature. This article here, which was typical of many over the last few decades, and it was published in Pre-Hospital Emergency Care back in 2007, so not new, studied the prevalence of MRSA on ambulance surfaces. And they found that their study showed that despite the standard cleaning that ambulance crews perform, ambulances tested had a significant degree of MRSA contamination. So this child here is fine, by the way. That's my daughter, who was very much acting the part for a photo shoot for a journal article about pediatric respiratory distress. And man, she really managed to look sick for those pictures. They were great for their purpose. But looking at those pictures now, I cringe knowing just what she was subjected to in the back of that ambulance, because I know what the ambulance cleanliness standards were at the time. So this was back in 2017, or maybe it was 2018 as well. So this was, again, recently pre-COVID. So, of course, COVID has changed everything. And now ambulance cabs and patient care areas receive much more attention than they used to. Typical of many EMS agencies now, Acoma EMS uses a multi-step process to clean their ambulances and stations. This is their frontline unit that is airing out after being fogged with disinfectant, and that's the fogging device it's on the cot next to the left of the monitor in this picture. There are different fogging devices on the market, and I'm not sure exactly how they work. And I'm showing Acoma's because that's the one I was able to get pictures of. It's certainly not an endorsement of one brand over another. And such devices are used in retail establishments, hotels, other settings as well. They're not healthcare specific, and I'm sure they're pretty hard to come by right now with all of the demand. Acoma also has several different sized ultraviolet disinfection lights. This small one right here, they use for disinfecting their phones and small equipment like safety glasses, pins, stethoscopes, masks, etc. They have a slightly larger one for bigger equipment like medical bags, monitors, other things like that. And then they have this giant one that they use in the back of their ambulance and in each room of the station. And they UV the station every day. Here it is in the back of the ambulance. Obviously, they close the door before they turn it on. It has a 30-second delay, so don't get a tan while they're cleaning the back of the ambulance. But they use the UV lamps in the ambulance and the station after fogging. So they fog first and then use the UV lamp after that. And they run the UV lamp for the full 60-minute cycle. During this time, they do have actually they have 3 trucks now. But they will use their second line ambulance if another call comes in while they're fogging or while they are disinfecting the primary unit. And again, while these pictures are from Acoma, they are typical of methods being used by EMS agencies everywhere on and off reservation, and certainly a paradigm shift from the pre-COVID days. Recently, you may have heard that the importance of surface disinfection has been questioned in the fight against COVID. And I don't know. I don't know how accurate that is. I know that we, as a society, are spending an awful lot of time disinfecting surfaces, in addition to all the other things that we're doing. But I just don't know what to think about that. But given the large body of pre-COVID evidence suggesting that pre-COVID ambulance disinfection was suboptimal for lots of different organisms, I think this practice will persist and be refined long after COVID is gone, which, of course, hopefully will be soon. So we've talked at this point about COVID-related changes to dispatch, to treatment guidelines, to personal protective equipment, and to disinfection of the EMS work environment. All of these changes have been aimed at directly protecting providers from the virus and by reducing their chances of contracting the virus while unprotected. They've had the side effects, I think, of protecting patients from getting infected while having contact with EMS personnel. But EMS providers have also embraced community and public health initiatives aimed at community level infection control, efforts that, of course, affect the public, but also affect EMS patients and, as a result, the safety of EMS providers themselves. This is a typical brochure for COVID-19 testing in the Pueblo of Laguna, which is carried out entirely by Laguna Fire Rescue personnel. The Pueblo of Laguna Fire Rescue is actually an excellent example of EMS involvement in COVID testing. At the outset of COVID operations in Laguna, to run the Laguna COVID testing program, the Laguna Fire Rescue C-Shift paramedic lieutenant was moved into the Laguna Emergency Operations Center to serve as the testing group leader. And this is her on the left. She has become a COVID testing expert and has led the testing group since its inception in the beginning of the summer. So testing now takes place daily in Laguna, except on vaccination days, which we'll talk about in a few slides, and is performed again entirely by fire rescue personnel. For quite some time, Pueblo of Laguna remained COVID-free, even as COVID was taking off in surrounding areas. But as COVID spiked in New Mexico, COVID eventually made it to Laguna. At that point, the Laguna Fire Rescue EMS lieutenant, who is here in the shadow under the awning, was assigned to be the contact tracing group leader in the Emergency Operations Center. So she now leads a team of 10 contact tracers for the Pueblo, who not only perform contact tracing, but also perform regular phone follow-ups on patients that are quarantining at home. This team has responded rapidly to outbreaks and has played a very important role in reducing spread. And they have been able to identify when quarantine patients need EMS transport to hospitals for further treatment. And these testing and treatment efforts have been central to infection control within the Laguna boundaries, of course, benefiting tribal members, but also benefiting EMS providers as well. And finally, both the Pueblo of Acoma and the Pueblo of Laguna chose to partner with the New Mexico Department of Health instead of the Indian Health Service to distribute COVID-19 vaccinations to their respective pueblos. Both pueblos designed and implemented drive-through vaccination operations well before operations began elsewhere in the state of New Mexico. While the details of the two operations differ, both operations use their EMTs and paramedics almost exclusively to provide the vaccinations and the post-vaccination monitoring. This picture here on December 16th, 2020, shows the lead health commander of the Pueblo of Acoma Health Command receiving the first COVID-19 vaccination for a tribal member in the state of New Mexico. And that's an Acoma Fire EMS EMT and lieutenant who is giving that first shot. You can see there are lots of phones there taking pictures. Mine, of course, was on this from this angle because I was taking this picture. Definitely a momentous occasion. Later that afternoon, Pueblo of Laguna began their vaccination efforts, also starting with emergency and essential personnel. So I mentioned that both the Pueblo of Acoma and the Pueblo of Laguna vaccination efforts are drive-throughs. So except for the on-duty personnel who were walk-ups, like in the previous two slides, everyone stays in their cars for the vaccine and then drives over to the observation period, remaining in their car for that as well. So EMS providers administer the shots, and EMS providers observe and check on those in the observation area afterwards. This one right here is in Laguna. It is their version, and that is housed in a large industrial complex adjacent to their public safety headquarters. You can see there's a convenient sheltered drive-through area there for them to be able to vaccinate people in several cars at one time. Acoma's version is outside at the entryway of their casino. It's sheltered by the entryway of their casino, but it's still outside. These pictures here are from last Friday, January 15th at the Acoma vaccination pod. Acoma and Laguna are both well into vaccinations for the elders in their community. I believe they are both, they've both vaccinated over 800 people with at least one shot, and many have already received their second shot as well. And in these two pictures show an Acoma EMT vaccinating her grandparents. These pictures are, at first glance, of course, documentation of an important public health initiative, which is remarkable in its own right. But the planning and tribal self-determination that made these events possible is less visible, but certainly remarkable as well. These pictures here also speak of the training of EMTs to function as public health workers and champions of public health infection control. And they highlight a tribe's effort to protect and respect its elders, and therefore its history and its culture. And of course, finally, the image of an EMT vaccinating and caring for her own grandparents, all of whom I know very well, is very touching. And I stress that these pictures are used with permission, and because they wanted to help spread the message. And to be fair, in a similar photo from Laguna, got to make sure that I'm giving equal attention. The Laguna fire captain in the operation vest watches and photographs his wife receiving her vaccine from one of the Laguna fire lieutenants. Now, I love the fire captain. He's a great guy. But I'm sure that all involved agreed that his wife was better off getting the shot from the lieutenant and not him. But seriously, having her vaccinated protects her and it protects him. Again, making these efforts an important component of EMS infection control as well as community infection control. The latest enhancements to the vaccination program in Laguna is an in-home vaccination of homebound tribal members. Some are truly too fragile to be driven to the drive-through vaccination pod. And for that small segment of the population, Laguna Fire Rescue EMTs and paramedics provide vaccinations and post-vaccination observation in the patient's home. Due to obvious logistical challenges, this is restricted to the truly homebound, but is an important part of the initiative to get all patients vaccinated, especially those who would be most at risk of adverse effects from COVID-19. And this is just a picture of my truck and the Laguna EMS lieutenant's truck parked outside of a homebound patient's home after we vaccinated and observed. And I just, right before starting here, got an email from Acoma. They are going to try to start in-home vaccinations on Friday for several of their members. So to wrap up, EMS infection control has changed for good and for the better, I think, as a result of COVID-19. EMS personnel are much safer now, and frankly, the patients are too, because of the changes in provider PPE and equipment cleaning and sterilization. But EMS's integral role in public health with testing, tracing, and vaccination will outlast COVID as well. EMS's involvement in population-level COVID-related infection control has proven that EMS providers and EMS systems are excellent and natural public health partners. It will be interesting to see how this partnership matures over the long term, and I hope to be able to come back to share that with everyone here. So with that, thank you all very much for your attention and the opportunity to speak today. And thanks also to the EMTs and paramedics shown here from Acoma and Laguna and Pine Hill and Tahajale, who continue to work hard to make a difference in the COVID-19 pandemic. So I would like to now answer any questions that you may have. So not sure what the best way to do that is. I see I do see in the Q&A, how many in-home vaccinations have been administered? I believe, since this just started, I believe that in Laguna we have 5, and I'm not sure how many they are planning tomorrow, because tomorrow is another Laguna vaccination day. And I'm not sure how many they are queuing up for on Friday in Acoma. Unfortunately, I'm not going to be able to attend either of those because I'll be working in the emergency department clinically, but of course I'll be on call for them if they have any questions. I'm happy if people want to unmute and ask questions by voice too, if you want, or we can go through the Q&A bar. Question, which vaccine are you using? We are exclusively using the Pfizer vaccine right now, since that is what has been provided by the state of New Mexico. I think the which vaccine would you like to be used? Question is whichever ones we can get. I think that that will that we'll see how that goes further. Next question. Did either Laguna or Acoma have to ramp up personnel to meet these new EMS roles regarding COVID-19 response and vaccination? So in state of New Mexico, vaccination and intramuscular injections are within the state scope of practice for EMTs and above. So they already had the training. And in Laguna, for many years, at least 10 years, we've done an annual flu vaccination pod where EMTs and above have been the exclusive providers of the flu vaccine. So this actually, in many ways, was only a slight variation on business as usual for Laguna. Little less common for the folks in Acoma, but we didn't really have to do much at all. We have attempted to get additional personnel simply for the added call volume from COVID, but that really hasn't been affected by the vaccination. There have been some folks getting a lot of overtime for vaccination, but that's about it. So the next question, do we need to quarantine when we make a day trip to another town, especially after we've gotten our vaccinations? So at this point, and this is the somewhat frustrating point I find, at least for right now, I think my recommendation in my own personal practice is to not change any of my behaviors based on my vaccination status. I was very excited yesterday when I passed the 7 days past the second shot milestone, but I am still, and my family is still masking, social distancing, not traveling. I think that on the national level, as we get more experience with folks who have had the vaccine and that we see they are actually not getting sick, I think that some of those things will change. But for the short term and maybe the midterm, I think things will stay the same. So next question, what is the biggest infection control challenge for EMS at this point? I think the biggest challenge right now is not does not have to do with the infection itself. I think people, at least in our areas, are very cognizant of the infection and almost too cognizant, because I think people are afraid, so afraid of getting COVID that they are not accessing medical care when they should. People are not calling EMS for chest pain. People are waiting too long for to call for a stroke, and things like that. I think that in many ways, our messaging to stay home unless you're really sick has almost been too good, because some people are just not getting the health care they need, non-COVID health care they need, when they need it. And then, what is the experience with vaccine hesitancy in the community? That has been varied. There has been a certain degree. I don't have a percentage, or numbers, especially since I have not been the one directly calling people when they're on the list to say, okay, it's your turn. I have spoken to a lot of patients directly, explaining why I thought they should get the vaccine. And in many cases, patients who are on the list in Laguna and on the list in Acoma have had concerns, and I've spoken with them. And I think that those who I've actually spoken to, I think just about all of them, if not all of them, have ended up coming through the vaccination pods. Now, I don't know if that's if those were folks who were probably going to come anyway. I don't know if I really changed anybody's minds, so I'm not sure. Another question: have there been any adverse reactions to the vaccine? From a worldwide perspective, yes, there have been some. It's a very, very low number as far as we know, based on what is being reported in the media, a very low number. As far as in our areas, we have not seen anything other than sore arms, or maybe a little bit of very transient paresthesia in the arms. And that has not, I mean, those have all resolved. We have not had anybody transported to the hospital out of the vaccination pod. We've not had to give anybody epinephrine. Everything has been very safe, almost medically boring in the observation area, which is exactly what we want. Another question: have you had to turn away giving vaccines to persons with allergies? And if so, which allergies are contraindicated? So as far as allergies to the Pfizer vaccine or the Moderna vaccine, I'm not sure of the others yet, as we're still waiting on those. It's the polyethylene glycol is the only absolute contraindication. An allergy to polyethylene glycol is the only absolute contraindication to either of those. That's I guess it's an inactive ingredient, unless of course you're allergic to it, then it becomes very active. So we have not had to turn anybody away. Well, I don't know that. I don't know if some people have been self-selected before I have become aware of them. But I don't think we've had to turn anybody away at the vaccination site because of allergies. We have had to turn people away because they have gotten other vaccines within the 14-day window. You're not supposed to get the COVID vaccine if you got a vaccine of any kind within the last 14 days, or are planning on one within the next 14 days. So there have been a few people that were turned away for a shingles vaccine, and there was one who got a tetanus vaccine. And there was also somebody who got a tetanus vaccine after the first COVID dose. And I think it was 14 days after, but that meant it was 7 days before the second COVID dose. So we had that patient wait an additional 7 days. Is vaccination open to the entire community at this point? No, but it's getting close. I know that Laguna is now registering people that are 45 and up, and that's after they started first with both Pueblos started first with essential and emergency personnel, and then elders, and then I think 75, and then 65, and then 55, and now Laguna has opened up to 45. I am not sure if Acoma has done so yet. If they haven't, it's going to be very soon, since both Pueblos are about the same size, and they're going at roughly the same pace. Someone has raised a hand. Go ahead. If you want to unmute, you may go ahead and ask. I'm not able to, if you are asking a question, I'm sorry, I'm not able to hear. Can anybody else hear? No. Let's see.
It looks like she lowered her hand.
Well, I'd still like to answer, if possible.
Evelyn, if you'd like to ask a question, go ahead and type it in the Q&A or in the chat. We weren't able to hear you.
Well, if there are any other questions, please feel free to add them in the chat, and I will also put my email address here in the I'll put my email address in the chat. If anybody has any questions, please feel free to email me. All right, well, I think I was able to fill all the time after all. So thank you again very much. Thank you for having me. Thank you all for attending. And like I said, please please let me know if you have any questions. Oh, here we go. After you clean the ambulance with the aerosol, what is the other item you used? That is the ultraviolet light. So that's just a disinfection system. And again, I don't have a preference for which brand. There are several different ultraviolet light disinfection systems that are ambulance sized, room sized. My father-in-law is a dentist. He has a giant one for his dental practice. So there are various different options in that regard, but fogging first, and then the ultraviolet light.
Okay, that looks like it. Thank you so much, Dr. White, for the presentation. And everybody, just a reminder that the evaluation will be available soon. Please complete that. And something I didn't mention at the beginning, this is a webinar, part of a series of webinars that we have on the Project Firstline project that NIHB has several partnered with the CDC for this project. So watch for future announcements and other activities for the Project Firstline project. And thank you, everybody.
Great. Thank you, everyone. Stay safe and healthy.